Thank you, sir. First of all, thanks Diabetes India for giving me this opportunity today, and thanks Tejas Bhai for standing us besides me for opposing what I am going to tell you today. And thanks Shubhashri ma'am for being here and introducing me. So this actually depicts the CGM, what CGM is actually. And you can every time see your speedometer or the RPM meter of your car, you can imagine looking at a CGM device. So I am defending this that should continuous glucose monitoring be recommended to all diabetes patients regardless of type and comorbidity. I have no financial disclosures for this talk, and we all know that managing type 2 diabetes is a very tight rope walk between hyperglycemia and hypoglycemia. And we all know that this is how CGM has evolved. I will not dwell into deep down science of this. The journey from SMBG to CGM, it's long, we all know, but we all know this thing that even frequent testers often miss the significant glucose fluctuation. And CGM, just like I told you, it can capture minutest value as well. Why do a CGM? Because this is how a finger prick looks, and the graph is there for CGM. This is how CGM looks like. So choice is yours. You want to see a photograph or a videograph, because this is something like this, like seeing a snapshot of a roller coaster or recording whole journey through a video. This is again one of a way to simulate this. A glucometer is on your left and CGMS is on your right, where we have a video camera and a still camera to compare. Just like ECG and a Holter monitoring, these two things are similar. And this is how we monitor our glycemic control in this era itself, which is a pity itself for most of our patients. Now, what are the limitations of the current monitoring methods? Just I want to highlight because I am defending CGM. So HbA1c, although being standard of care, but the impact of hypoglycemia and hyperglycemia are unknown, and we cannot deduct glucose variability with it. SMBG, hypoglycemia and hyperglycemia are often missed because we don't check often, and overnight data is impractical. Patient needs to be actually awake to collect the data. 7% HbA1c, we all know, we have seen this slide many times. It can reflect, 7% reflects on CGM in a different manner to different patients, and that is why CGM becomes more important. One more thing why we should have CGM is MARD, and don't confuse this with MERV. The MERV was movie of Amitabh Bachchan. This is MARD. MARD is actually a coefficient of variance because it gives a variation in the readings, and this is how your glucometer behaves. This is the MARD values of various glucometer, and they hover from 6% to, let's say, 22%, while accepted MARD is less than 10. And that is why actually I believe CGM does better, because this is MARD value of CGM devices. These CGM devices, they all have a MARD value less than 10. So the lesser the MARD, the better the measuring device is. This is one of the reasons why we should prefer CGM over conventional things. Now, the type 2 diabetes journey, we all know this is a long path, and this is actually the consensus statement which was given for the time in range. In India, the consensus told 2-3 things, because these recommendation came from the consensus statement which is there in India itself. And the need for customized guidelines for CGM is there, because we cannot look at the guidelines which is from Western world, because we have a high carb diet, we have ethnic differences, cultural and regional practices, geographic variation, psychosocial behavior, and unique cluster of type 2 DM. So we need to have a customized guideline, and the consensus clearly says that it is recommended for all patients, especially pediatric patients with type 1 diabetes, to reduce TBR and reduce instances of hospitalization. I will come to that later. The newly diagnosed patient. There is enough data to support that newly diagnosed patient, when started or when given a choice to be on CGM, the pilot feasibility study clearly told us that they sometimes undergo a remission. The A1C reduced by 1.8%, 80% patients classified as responders. They show a mean HbA1c change of 2.3, and 67% achieve remission when they were given CGM right at the time of diagnosis without any therapy. So this is something phenomenal for our patient, because we really want to cure them, right? Now, it again gives them a way of managing and remission. It brings out the desired lifestyle changes, and it delays the introduction of glycemic therapies, because we all know what we want is a cure, and patient also wants the same. Now, again, moving further, this clearly shows that we can identify glucose patterns and glycemic targets. The patients who are afraid to initiate insulin, CGM can help alter their lifestyle and convince them to initiate insulin if at all it is required. It again benefit in special population like pregnant women because it is best for neonatal outcomes. Various studies are there and they have shown that CGM based method can reduce large for gestational age, neonatal hypoglycemia and neonatal ICU admissions when they are applied to the pregnant females. Monotherapy. When monotherapy comes, the flash glucose monitoring help achieve a better glycemic control. There are various studies to prove this. This is change in HbA1c when we give SMBG as compared to the flash glucose monitoring, and you can clearly see the flash glucose monitoring fares much better. This is again an immediate study which shows the impact of flash glucose monitoring in people with type 2 diabetes which are inadequately managed with non-insulin anti-hyperglycemic therapy. It was a RCT and it clearly showed that the patients who were not adequately controlled became better when CGM was applied before initiation of any insulin-based therapy. Combined non-insulin therapy, when we see the use of CGM for 2 weeks mere can help us readjust and modify most of the therapies. And that is a edge because we want to escalate to insulin at that point of time. And at that point of time, if we apply CGM, we can readjust the therapy to get in sync with the glycemic value. And we can actually get the desired TIR within them without even going for insulin. So we can do early detection of low glucose, especially in patients who are on sulfonylurea. We can enforce lifestyle changes because many times we see patients on polypill, he forgets about lifestyle. So we can force them back to the lifestyle. We can monitor the effectiveness of existing and newly introduced therapies as well, so that we can make our prescription more rational and more precise. Patient on insulin therapy. There is enough data. Gold 3 study we have seen many times because CGM we have seen it reduces the time in hypoglycemia. It improved hypoglycemia related confidence in patient. It improved the well-being and quality of life. The silver study, beneficial long-term HbA1c control and treatment satisfaction with CGM. A diamond trial was there which improved HbA1c and reduced the time spent in hypoglycemia. So these all gold, silver, diamond favor CGM as compared to the conventional therapy. Now diamond study, it again gives a better glycemic efficacy and safety with CGM as the usual care. A significant reduction in HbA1c with lesser duration in hypoglycemia in the CGMS arm. Now again, this is a graph which shows the longitudinal changes in continuous glucose monitoring use among individuals with type 1 diabetes, and you can clearly see the CGM fares much better than the SMBG. These are all the data to support it. Now this is very interesting, a meta-analysis of clinical trials and real-world observational studies which shows the impact of flash glucose monitoring on glycemic control, and you can clearly see the drop in HbA1c once you start flash glucose monitoring. This is coming without adjusting the therapy itself. Now there are abundant evidence I have shown you. Even I can show more, but time doesn't permit me. So it is in type 1 diabetes that CGM standalone improves glycemic control, significantly improves the pregnancy outcomes in GDM, and significantly increases quality of life of patient. So this is an algorithm. CGM in type 2 diabetes without advanced classification. In newly diagnosed, it should be used. In monotherapy, it should be used. In combined non-insulin therapies, it should be used. In insulin therapy, it should definitely be used. Nephropathy, retinopathy, and neuropathy, because we have a lot of patients with retinopathy, nephropathy, and neuropathy. And when I digging down literature, I came across this line: individual with advanced renal disease, HbA1c holds no value whatsoever. You all know about it. So we need to make sense of glucose sensor in end-stage kidney disease. This is a beautiful read. Go and read this. This will change the perception how you monitor your patient with end-stage renal disorders, and you need to monitor them right. So this is correlation between mean glucose level obtained through glucose meter and CGM in hemodialysis type 2 diabetes patient. You can clearly see flash glucose monitoring. This is again Giotto study which clearly shows that it favors CGM as compared to the SMBG or HbA1c. Now, neuropathy. We have two types of neuropathy, autonomic neuropathy and peripheral neuropathy. And why glycemic control matters? We all know chronic hyperglycemia contributes further to the nerve damage. Hypoglycemia risk, especially in autonomic neuropathy. So, both the arms are dangerous. So, the CGM comes handy in hypoglycemic unawareness because most of our patients at point become hypoglycemically unaware, and CGM can help with the real time readings. Now, again, we need to have tight glycemic targets in retinopathy, where CGM can be handy. And it can avoid hypoglycemia as well, because advanced retinopathy patient may be at higher risk for severe lows, which can be mitigated through real-time CGM. Macrovascular complication. We are all worried with heart attack and silent heart attack as well. And this is a very beautiful study which shows glycemic variability is associated with myocardial damage in non-diabetic patients even. Leave and forget diabetics. In non-diabetic even, it is associated with myocardial damage. This is again, these two graphs are enough to explain that how the lower age group responds with the higher age groups and where our patients should land. Now again, it is there that CGM use post ACS in type 2 diabetes, macrovascular disease and hyperglycemia. Elevated glucose after acute coronary event correlate with worse outcome. Mind it, any patient post ICU care, you need to control the sugar as soon as possible. And post ACS, we should optimize glycemic control, minimize hypoglycemia to reduce the risk of arrhythmia. Macrovascular benefit associated with improved long-term cardiovascular outcome, and we can individualize the therapy adjustment as well. There is a strong inverse correlation between TIR and carotid intima media thickness, which is a proxy for cerebrovascular disease. So you need to be cautious about this and focus on TIR in your cardiac patients. Now, this is why it should be used in patients with vascular complication. Now, coming to the next part, in cancer patients with type 2 diabetes. So the patients who are on cancer, they have higher mortality, more unplanned admission, lower chemotherapy completion rates, and that is why it becomes imperative to have a tight glycemic control. And some agents which are cancer chemotherapeutic, they increase insulin resistance and impair insulin secretion. That is why it should be used there. Surgery. This is again a caveat point. Perioperative hyperglycemia and outcomes has been well established, and it has seen that hyperglycemia is associated with wound healing, which are worse and actually worse outcomes. So quickly and safely, we can improve glycemia with the help of CGM. Patient with disability, we can have CGM because visual impairment, physical disability, mental disability, and all these things are there, and it can definitely help. But there is an evidence gap, I will accept, but we should see a try and see approach, and we can evaluate the feedback based on this. We do it in our routine practice. Geriatric patients. This is a beautiful reach. Glucose targets using CGM in older adult with diabetes. Are we there yet? Because we are not doing right to them. We are not monitoring the hypoglycemias which are associated with falls and other things and arrhythmias in geriatric population, and where this can help. Now comes the complication part. Because we all know there is important drop in rate of acute diabetes complications in people with type 1 or type 2 after initiation of glucose monitoring. So one will want their patient to be admitted just by mere fluctuation of blood sugar values. And this is again a relief study which is showing that there is a significant drop after initiation of CGM in acute admissions in hospital. This is a forest plot which clearly shows that after initiation of flash glucose monitoring, it benefits after 1 year of installation of Freestyle Libre, which was done to the patient. There is a decrease in hospitalization, another paper for acute diabetes events following Freestyle Libre, another one. So there is enough evidence to support that the admission rate goes down for patients, those who are initiated on a flash glucose monitoring. Again, one more paper on acute admission quality of life, which supports this. And it actually reduces the overall cost burden of disease, because a point will come where we'll talk about cost. So the cost of admission is much higher than the cost of a CGM for many patients. This is the difference in terms of euro. So these are all the societies which actually endorse the use of TIR in addition to HbA1c. We cannot just rely on HbA1c. We need to see the TIR of the patient. We need to see the glycemic variability. These are ADA standards of care which clearly says that adult with type 1 diabetes, adult with type 2 diabetes, children, adolescent, pregnant women, they all should undergo CGM. This is RSSDI clinical practice recommendation, which clearly says that 14 days of CGM is required for assessment of time in range of at least for at least 70% should be in time. These are patient scenarios where it should be used. This is a workflow for how to put sensor and when to put sensor. With that, I thank you all for the patient listening. We should learn to check blood sugar and we should check it much often than what we are doing. Thank you.
Thank you. Thank you very much and good afternoon to everybody, and a big thank you to the entire team of Diabetes India for having me here, and thank you, Bharat, for making my job a bit more easier. I think the topic as what we are discussing is we are not meriting CGM. We know what benefits CGM has. We know what demerit CGM has. So my take is going to be a bit different because the topic says that should CGM be recommended for all types of diabetes, and that is what we are going to discuss. Thomas said that we were promised a simpler life and technology has only complicated our lives. We have many advances in healthcare, but all advances over a period of time has not led to better outcomes. And that is what again we are discussing. So imagine a world, Bharat showed a picture of CGM in the start where he showed a RPM being moved, and that's where and this is something similar. We imagine a world where a driver who's driving once in a day or maybe he's driving once in a month, he's forced to put a GPRS tracking, which is tracking his location, which is tracking his movements, which is tracking his history day in and day out. You imagine this scenario. Isn't it unnecessary? It leads to constant alerts, disruptors, focus. He loses focus. It basically is a system that actually gives less benefits and affects him more. So that is what we are debating. A CGM has its merit, but whether it is mandatory for each and every kind of patient with diabetes, somebody who doesn't need monitoring, somebody who doesn't need those frequent alerts, somebody who's doing well on exercise on just one or two simple drugs, do we give CGM to them also? Maybe it's impractical, maybe it's not reasonable, and it is a burden financially. So my take is that CGM should be there for patients who need it. CGM should not be a uniform requirement, but maybe something which should be an option, which you should select based on individual needs. We have a number of good things in the world available, but do we make that compulsory for all? No. So therefore, just because you can, it doesn't mean you should, is what we should always remember. Now, as a doctor and as as leaders in our field, what do? We write a prescription based on evidences. We we prescribe a patient drugs based on guidelines. So when a doctor makes a recommendation, it is considered to be evidence-based and it is grounded in the best possible research and guidelines and not just personal opinions. So that is what we are looking at. When we started writing SGLT2s and DPP4s and GLP-1 agonists with metformin above an SU or above any other drugs, it is because the guidelines taught us and evidence told us that it gives benefits over a period of time. And this is what, let us look at what the guidelines are saying today for CGM. Do guidelines tell us that you use it in all patients? No. The ADA 2025 guidelines, Bharat just showed just now. Yes, for adults patients with type 1 diabetes and for younger patients with type 1 diabetes, absolutely, it's a must. I definitely agree to that. For patients who are on multiple insulin therapies, yes, the ADA recommends that you should use a CGM and we should use a CGM. What about other patients? No, it is not there. It is not recommended for each and every patient. The ADA says that in people with type 2 diabetes who are not taking insulin, routine glucose monitoring may be of limited additional clinical benefit, and therefore it is not a necessity to be done. Initiation of CGM should be offered to people with type 1 diabetes early in the disease, even at the time of diagnosis. But people with diabetes on insulin therapy, on intensive therapy, yes, it should be used. But people with diabetes on insulin, type 2 diabetes, based on insulin are recommended because there is no data which has shown that those who are on prandial insulins benefit with CGM. Again, in this subset of patients, it has been seen number of studies have shown that the primary outcome of a reduction in severe hypoglycemia actually was not met, and the incidence of severe hypoglycemia was not different for patients who are using CGM versus as an SMBG. RSSDI 2022 guidelines. Again, there are clear recommendations for CGM. You can use it, or it is found to be beneficial in patients who have severe hypoglycemia, hypoglycemic unawareness, those with pregnancy, infants and children receiving insulin therapy, those who are in basal therapy, and those who are on drugs which may cause severe hypoglycemia. RSSD has mentioned, a real-time CGM alone is not recommended for glucose management in the intensive care unit or for in an operating room, and it should be with the help of an SMBG. Important point again here is real-time CGM again, irrespective of the status, should again be used for only for subset of patients who are on multiple insulin therapy, and the intermittent use of CGM designed for short-term analysis may be of limited benefit. Now, coming to pregnancy, again, there are two different studies which have shown that use of real-time CGM did not show difference in neonatal outcomes and in patients, even in patients with type 1 diabetes. And this data is insufficient to show or to recommend the use of CGM in all pregnant people with type 2 diabetes. It's not moving. Okay. Now, when the mic is not working, I think. Okay. The decision whether to use CGM in pregnant individuals with type 2 diabetes or GDM should be individualized based on the treatment plan, circumstances, and depending on what kind of therapy that the patient is on. This is what the recommendation again from ADA 2025 says. The Endocrine Society clearly recommends short-term intermittent real-time CGM in patients with type 2 diabetes who are not on prandial insulins. The US recommendation again says that CGM in type 2 diabetes can be used in patients who have severe hypoglycemic unawareness or having severe hypoglycemia, but not all kind of patients. This is a paper by Dr. Bansi Sabu, who also recommends or which says that which is about recommendation in South Asian population. And again, if you see clearly, the CGM recommendation is once in 6 months for patients who have a TIR of more than 90. For more than 70, it is only once in 3 months, and for those less than 50, it is once in 2 months, but not on a day-to-day basis. Now, why do we write a therapy? Because it is based on evidence whether it gives us benefit or no. So, has CGM demonstrated any outcome-related benefits in patients with type 1? This is one of the studies which again was done in patients when we compared CGM use versus SMBG. And again, the difference in HbA1c between the two arms was again only around 0.2%, and there was no meaningful clear difference in terms of adverse events, in terms of hypoglycemia. The arms were same. This is an interesting report by Robertson, which again questioned the use of CGM as a widespread adoption. It made up impacting on the points that there is no microvascular or macrovascular outcome benefits seen with long-term CGM in patients with type 2 diabetes till now. Such not the severity of hypoglycemia, or it does not decrease the incidence of hypoglycemia. It only alerts the patient regarding hypoglycemia is what the argument is. And of course, it gives me a deal of stress on the cost aspect. We have asked again, which means long-term benefit. It looked at HbA1c, it looked at the quality of life in patients who are put on CGM versus SMBG, and there was no difference in terms of quality of life and as well as there was no difference in terms of HbA1c, only 0.2 to 0.3%. Now, coming to the cost aspect again, we are from our pockets. We have new patients are paying with their own money. Insurance does not cover any CGM. And therefore, we were especially recommending CGM to our patients. The cost of a CGM simple sensor in our country is somewhere around 80,000 to 1 lakh per year. If they are patients doing it more regularly, at least twice a month. And whether this extra cost is necessary, but it is right in terms of especially for patients who do not require it or who do not require this monitoring. So, what are we expecting from CGM and what are we getting? Are we getting an improved quality of life for all kind of patients? Does the data show that? Are we getting a different HbA1c difference? Does the data? No, we're not sure. Coming to, again, hypoglycemia field, I will really for patients who are prescribing only maybe a metformin or a DPP-4 or an SGLT2. We start off with newly diagnosed patients who are mainly on diet and exercise. Are we telling them to do an SGLT2? No, I'm sure none of us get for any patients who know I'm not going to go into hypoglycemia. Why do we tell them to do an SMBG on day-to-day basis? Now, it is some of the areas where CGM does cause us concern. Well, if you look at patients with GMT and patients having CGM, the right notice it has to be highly motivated patients who can take care of themselves. Which are seen in our cities, which higher in the CGM arm as compared to the other arms. Second, hypoglycemia, I showed that there was more hypoglycemia actually seen in the CGM arm as compared to the other person. Other second, the CGM accuracy, there is almost a 40% change in terms of because of the difference in the interstitial fluid depots versus the depots measurement that is seen and in terms of the interstitial fluid depots fluctuations that are seen when the hypoglycemia is there. It is been clearly documented when the hypoglycemia is seen, when the body is more than 400 to 5, CGM does not show an accurate reading. So, calculation is important. Which are up to 400 should be avoided, is what the recommendation is on a CGM basis. Now, coming to HbA1c, why we trust so much HbA1c? Because it has shown it's a simple, it is moved for years, for the last more than 20 years, and all the benefits or outcome trials have been done on HbA1c, which show that the reduction in micro and macrovascular outcomes are based on the reduction in HbA1c. The CGM of it's interstitial fluid doctors. It doesn't apply. No, I don't think so. CGM in hospital actions, it is very acid on CGM targets, on clinical interpretation guidelines. CGM should confirm with CBG what the guidelines are telling us. The society recommends caution when we are using CGM, especially if the patient's blood systolic blood pressure is less than 100. The Diabetes Technology Society again recommends that you should not be using CGM if there is severe hypoglycemia of more than 500 or a severe hypoglycemia less than 40. The ADA recommends that you confirm CGM readings with a POC reading, which is necessary. And the OS recommends that the patient should notify the primary team to confirm the POC blood glucose when the CGM results again are showing erroneous results. So I'm going to show of hands here in the last 2 minutes. There are different kinds of patients that we see in a clinical practice. I want to know how many of you will be comfortable with CGM for this kind of patients. Diabetic patients. Type 2 diabetic patients on insulin intensification. Yes, I also agree. Newly diagnosed patients on metformin, on DPP-4, on SGLT2, don't require monitoring. I can see 2 hands. Type 2 diabetic patients, moderately well controlled, longer duration, on PHs. Okay. The pregnant patients, only on metformin, only diet control, not on insulin. Okay. I think the answer everybody is given. So let's think again, friends. Monitors for all kinds of patients with diabetes is not necessary. But is not one size fits all. And forcing CGM on all patients actually ignores the individual needs and preferences. So instead of blindly imposing all our technologies, the solution is not universal CGM, but solution is to be smart, give a personal approach in diabetes care. So should CGM monitors be recommended? I think the answer is no for me. Thank you.
Very long, don't worry. I mean, I'm a GP. I'm a family physician based in the city of Barcelona. I have the honor to chair a non-profit organization, the only one in diabetes in Europe in primary care. So Primary Care Diabetes Europe. We have a journal index that is Primary Care Diabetes. But besides that, I'm doing clinic in the city of Barcelona in primary care. I'm a professor at the university as well. but also in the past 5 years are more involved working with the Minister of Health in trying to incorporate innovation and research in the system. Okay, so I'm a civil servant. Now I'm working as a private doctor. I'm visiting patients. I'm in the real life visiting patients and also working with persons that are making important decisions. Okay, so that is important related to what I would like to share with you. The first thing, I would like to clap both of you because I think has been fantastic review for both. I mean, I think it has been for me. It has been a pleasure. Barack and Tejas is the names. Tejas, Barack Tejas. No, okay, okay. So let me just. I mean, I can move forward. I've been working in the last years in CGM because I've been working in a paper that has been published recently about recommendations how to use it CGM in type 2 diabetic patients. So I've been working on that paper together with other colleagues. And now we are ready to publish a new paper. Is a narrative review that is state of the art how to manage CGM in type 2 with insulin therapy, because sometimes it's very challenging to coach clinicians how to manage, how to understand CGM in terms to move up and down those persons with type 2 diabetes. Okay, here is a question of a debate. Okay, and we have in one side Barack, in the other side Tejas. No, Tejas. So please, just to start, who are in favor of who thinks that Barack is probably must to win? Just raise your hand. I mean, don't be shy, please. I mean, don't be shy. So just 1 hand, 2 hands, 3 hands. So the other ones are in 4 hands, 5 hands. So the other ones are in favor of Tejas. No? Okay, so I'm sorry, but it seems that Tejas has been winning the debate. But probably we need to know that this is a controversial thing, and that's why, because I think that from the very beginning, nobody knows how much things we can extract, we can distill from the CGM. These new concepts of time in range, time below range, and I think that if we, and yesterday, and it's not my personal perspective, it was Patar Khan, a colleague from the UK, said, what do you prefer, a Ferrari or you prefer an Honda? Maybe you prefer a Ferrari, but the thing is that probably you need to know if you can pay the Ferrari and the oil that Ferrari consume. And here is the point. Ideally, I prefer to have CGM for everybody. Because I mean, I prefer to have, as has been said in a very elegant manner, in a metaphorical way, Barack say, what do you want, a picture or you want all the movie? No, I prefer all the movie. Because then I can understand what's going on. The thing is, we can pay all the movie, or all the movie, it has sense for everybody. Okay, so that incorporate another factors, another aspects. And here is how I interpret this in my perspective, in the position where I am at the moment. Okay, so can we pay that? And I can just move to another domain where we are, a lot of us, very concerned. Obesity, GLP-1 receptor agonist. Okay, if we know how much patients we have, or how many patients that probably could be recipients of GLP-1 receptor agonists, we can pay. The governments can pay the amount of money that it costs GLP-1 receptor agonist treatment for our obesity or overweight patients, probably not. Okay, so probably we need to know which ones are going to be those persons that are going to benefit most of our actions, or those interventions that have more benefit. It's clear that it's cost effective. So, of course, in each country, there are different rules. Okay, in my country, for example, CGM is for free for the citizens with type 1. They don't have to pay. It's free access. No, they just receive at home because they ship it to their homes. Okay, in type 2 diabetes, they have the same case, but just when you are insulin intensive patient, not the other ones. Okay, but all the type 2 insulin intensive patients benefits for CGM? they are reacting. That's the other part of the story, is how tight we are in terms of being, I mean, the structure, the healthcare systems to be prepared to coach this technology, because the technology goes so fast. But how we are as a clinicians and the healthcare systems prepare to digest this way of operating, because providing our citizens CGM, it means that we as a healthcare systems need to be prepared, need to be incorporating that data in the electronic clinical records, trying to cross the data with the clinical data, and trying to provide messages to the persons, and probably use that data to do research. Okay, and to understand that probably that 24 hours profiling is opening new windows, new evidences, new things. Like we observe, for example, with retinal photography, the patients with retinal photography and intelligent and artificial intelligence are projecting now, it depends of the photography, this person could have a higher risk of a stroke or a higher risk of heart attack, just with the photography and with artificial intelligence. Could happen something similar with the CGM registers and patterns? Could the CGM patterns allow us to understand that probably a patient could be better responder for one oral or another oral? This is potentials, maybe solutions in the future. When I say yes, and a person that at the beginning of the disease could be having one register, I think I will be very interested to know at the very beginning of the disease, what is the profile of that person, to understand somewhere the phenotype or the glucose profiling of that individual at diagnosis, because maybe that have an impact in terms that person is going to go better with vildagliptin or gliptins or sulfonylureas, or maybe with metformin, or this profile is not going to work with metformin at all, because this profile is much better to work with this kind of medication. So I think baseline, like a halter, baseline determination of CGM could be something interesting, at least from research perspective. That's my personal opinion. Of course, something that in my opinion is very critical is that we need, of course, in these infrastructures that allow to download these results, incorporate the results in the electronic clinical records, and then create a dialogue between the person and the system. The person can download the results on the mobile, but that information ideally need to go directly to the electronic clinical record directly, and maybe the electronic clinical record can provide some guidance to the person and telling the person, okay, with that results you have to do this or this, or go to the emergency or go to that. So create something else after the CGM, and that is according how we are providing care. We need to understand CGM as a tool that can improve our operations, how to coach persons living with diabetes and have benefit with the CGM. And of course, we need all of the systems, we need to be very precise, helping to have good databases that allow us to start with new questions, with new hypotheses, as I said. Because I think that all of this million of data, is fine that it will be on Abbott, on Dexcom, but must be in the electronic clinical records that allow to do research, okay? And that research allow to understand what is going on with that person's living with diabetes in that specific situations, in what therapies they are using. Of course, CGM is a tool, but it's not the solution, okay? And we have clear example for self-monitoring blood glucose, because I don't know, but I know what happened in my country, in my practice. All patients with type 1, with type 2 have free access to self-monitoring blood glucose. Everybody, strips for free, okay? All type 2 strips for free. How many of that persons on insulin, type 2 patients, are doing up titration and down titration? Probably less than 2%. So why they are doing monitoring if they are not reacting according to the results? So here I have an important concern. If we have a tool, we have to do something else, because we have to provide support to those patients, in that case, type 2s, I think, Type 1s, I think, is very covered, is very clear. But in type 2s, that they know to understand the results and they know to do what else after that results. If not, it's completely useless. It's very expensive. It's probably not important to be recommended. And that is why I think it's important that probably this CGM is not valid for everybody in type 2 in insulin. It depends if you are open to do movement in your therapy. So, of course, that requires training in GPs, in healthcare professionals, because I have a lot of my colleagues that don't understand the measurements, not the patients. The healthcare professionals don't understand what is behind a result, don't understand if it's better to do it fasting, postprandial, don't understand the profile. Imagine if you put that person's in front, that health professionals in front of 24 hours CGM register, that is going to be a nightmare. So we need to do all of those ones here that are very professionals, that are very trained in CGM. Please, this is a very important piece of advice. Support and coach your colleagues, because if not, this technique, this solution, this tool is going to be useless. Of course, that it means that you have to be champions in understanding what is time in range, what is time below range, above range, all of these parameters, how to move up and down on medications just to be aligned with the guidelines that you already presented, some of these here. If you have these targets, what you need to do, you move up, you move down, etc. And I think also you need to do this in a proper manner that the patient understand and makes these things their things. Because sometimes what is happening in our context in clinic, we assume that the persons just coming to the clinic, they understand 100%, and they go out and they start operating. That's not true. That's not true. The patients, when go out of our clinic, they remember 10% what we said. Okay, and they go to the pharmacy, they go to other places to double check if they understood something else. So please don't neglect the importance of when you are explaining that results, when you are sharing with them CGM things or SMBG values, because that is empowering the role of the person living with diabetes, and that is a key thing. We have good and amazing tool, but we have to elevate the value of that tool as a solution, and this is in our hands. Okay, so sometimes we have some problems in terms of connectivity. I think because I think the both presenters has been amazing. They've been providing the perspectives of the same thing, and I'm 100% sure. Okay, CGM is not for everybody. Okay, CGM, we need to decide which one are going to be the individuals that benefits most. But those ones that could benefit most, we have to do our job and also incorporating the person living with that condition in the process of management. If not, we are going to fail, because this is a tool, that is not the solution. The solution is the person living with diabetes, ours as a coaches, and the solution we put, the tool that helps them to understand what's going on with their diabetes. And also moving to a new fashion, and I don't know how it's here in Asia and in India, we are in Europe talking a lot now about what is value-based care. Value-based care. Value-based care is an approach that is trying to put all of these things that provide value in the first line and try and do something that is important. Probably there are many things we are doing in our performance that have no value. What it means that we start to do undoing things and building things, because there are many things that are incorporating in our practice that is some inertia and that is very low value. So focus on the high value actions, and probably CGM, mentoring our patients to understand CGM, could be a very high value action for those ones that we know we have evidence that CGM works. So my answer here is for type 1, yes. For type 2, in orange, okay? But yes, but in orange, because so many probably is not really recommended and is not cost effective, okay? So thank you very much, and I think now it's some closing.